Thank you very much, and thanks to the faculty for the kind invitation to be here. As with some of the other speakers, there's quite a lot to get through, so I'll fly through it. But these slides will be available on the Dropbox. There's summary slides for you all there, so if you don't manage to get everything, please don't worry that you'll be able to get the summaries there afterwards. So we'll fly through these 5 topics. And really just cover the basics of them. Obviously a lot more information is available, and you could spend 25 minutes talking about any one of these topics on their own. We'll start with the most common of the mucosal diseases, really, which is recurrent aphthous stomatitis. About 20% of the population get this, so 1 in 5 people at some stage in their lives are going to get recurrent aphthous-like ulcers. The thing that I'd like you to notice is the characteristic features of these ulcers. They tend to be round, they've got a red halo, and they've got this yellow or grey base. So that's very much typical of aphthous-like ulcers. And really there aren't very many other kinds of ulceration that look so typically like that. We subcategorize them as minor, major, and herpetiform. Minor being the most common, making up about 90% of the people who have this condition. Major making up the majority of the rest, and herpetiform being really quite rare. This table, again, you'll find in textbooks and it's in the slides, but they're the kind of typical differentiating features between them. Usually, clinical examination will show you quite quickly which category you're dealing with, and the history that the patient gives will fill you in on the rest. So you can see minor there on the far left of your slide, of the slide on the screen. Less than 1 centimeter, small, round, red base. The major one in the middle then, you're looking at almost all of the buccal mucosa there in that little rectangle. So that's about maybe 2 centimeters across. It's been there for 6 weeks, and it's going to take another few weeks for that to go away completely. And then the herpetiform on the right of the screen, multiple 1 millimeter or less ulcers, all kind of in a big red blob together. Some people think that this might be a totally separate condition than the other kinds of aphthous ulcers, but because it's so rare, we don't have much data. Nothing to do with the viral ulceration. It's called herpetiform because it can look like viral ulceration, but there's no viral cause for herpetiform recurrent aphthous stomatitis. Those little ulcers can also coalesce together and leave a larger, much more irregular shaped ulcer, which doesn't necessarily look typically aphthous, and that can confuse things as well. So what do we do with aphthous ulcers? You'll see these all the time in practice. You'll see people who get recurrent ulcers, and you'll see them when they happen to come in with an ulcer on that day. But probably the first and most important thing is to rule out the things that are not recurrent aphthous ulceration. So these are the things that can cause aphthous-like ulcers, ulcers that look just like aphthous ulcers but are secondary to an underlying disease. And we can break them up into hematological, GI, and inflammatory. The hematological ones, anemia being the biggest one, and there's a lot you could say about anemia, but any cause of anemia can cause aphthous-like ulceration. Hematinic deficiency, that's vitamin B12, folic acid, and your iron stores, ferritin levels. If they're a bit low, that's associated with recurrent aphthous ulcers. Is it the cause? Not quite sure, and the data is not there. Sometimes when we improve or increase those numbers by giving supplements, the ulceration gets less frequent or less bothersome, but rarely does it go away completely. And then neutropenia as well, a low white cell count, low neutrophil count is associated with this. The GI conditions can cause aphthous-like ulcers because they can all cause anemia and they can all cause hematinic deficiency. And then Crohn's disease as well can cause aphthous-like ulcers as part of OFG, orofacial granulomatosis. So separately to anemia, you can get ulcers that way. The inflammatory ones, Behçet's is the most important because it causes eye problems and can lead to blindness. It's also probably the most common of those rare inflammatory conditions. PFAPA, usually in childhood, that's periodic fever, aphthe, pharyngitis, and adenitis. Sweet syndrome is generally in childhood, and MAGIC is mouth and genital ulceration with interstitial chondritis. So that's probably a subvariant of Behçet's. Sorry about the color. Hopefully it's readable for you all. Where do we go from there? Well, we want to then look at how we can treat this. Well, we've ruled out systemic disease. Usually that's with blood tests and by taking a good history. I'll just see if we can fix that for you. Let's just try that. Give it a second to think about it. No difference, all right, but we won't worry about the colours. The topical treatments then, physical barriers, things like Carmelose, cellulose you can put on top, anesthetics, for the mildest ones. But really the mainstay of treatment is steroid creams, steroid mouthwashes, steroid sprays. So topical steroids work for the vast majority of people with aphthous ulcers. And systemic treatment is really reserved for the most severe, rarely needed for aphthous ulceration. Thalidomide is the only drug that stops people from getting new ulcers, but the side effect profile is obviously terrible. So the first tip, if you like, for this 5 topics, 5 tips, is not to forget those serious conditions, serious underlying causes that are rare in aphthous ulcers, but need to be ruled out. Moving on then to lichen planus, again another really common mucosal disease, very common overall, affecting about 2% of the population. It's generally middle-aged ladies, but it can happen in any gender and any age group. The mouth, skin, genitals are the most commonly affected surfaces. Nails, other mucosal surfaces like the nose and the pharynx are much less likely. And again, I just draw your attention to the differential diagnosis at the bottom there. It may be a little tricky for you to see some of these clinical pictures. Hopefully you can see the kind of reticular-like pattern. Again, the pictures are all in the handouts for you if it's difficult to see. The differential diagnosis for any lichenoid type lesion is lupus, lichenoid contact reaction, that's typically from amalgam restorations, although it could be any restorative material. Lichenoid drug reactions and chronic graft versus host disease. We'll touch on the drugs later on when we're talking about white patches in a more general sense. Clinical subtypes, reticular is the most common. Again, apologies about the color issue on the projector. And then really after that, we look at erosive ulcerative plaque-like papular bullous, but more common than all of those other subcategories is the mixed picture that we often see with lichen planus, where you get a little bit of ulceration, a little bit of erosion, and then generally with all of those you'll see some reticulation, some white lace-like patterns if you look closely enough. This is more of a plaque-like one, but again there's background erythema, it's an inflammatory process, and there is some reticulation if you look closely enough. The histology for lichen planus, again, a common question in these exams because it's an easy one. You'll get these classic features, hyperkeratosis or ulceration if there's a break, liquefactive degeneration of the basal layer, the sawtooth rete pegs, and you've got this big band-like inflammatory infiltrate, which is basically lymphocytes crowding into that area and causing the damage. And then within the epithelium, you'll get civat bodies. Treatment for this, biopsy, unless the diagnosis is really clear, I'm very keen on getting a biopsy, which is to rule out any dysplasia and to be sure that we've got the diagnosis right. Because these patients, we're committing to telling them they've got a lifelong increased risk of malignancy, they need to be careful about self-monitoring, and it's quite nice to know that you're sure of the cause. Sometimes there's a cause that can be removed, drugs, restorations, and then again we're into the steroids to treat these. Generally, about 90% of patients with lichen planus, topical agents are enough. And if we can get topical steroids into sore parts of the mouth, then that makes things better. We're also treating the symptoms. We're treating the soreness, the discomfort. We're not trying to get rid of the condition. There's no cure for lichen planus. So patients sometimes come back and say, well, it feels much better, but there's still white patches. And that's obviously normal. But it's important that we educate the patients to understand exactly what's going on. Systemic agents, again, you're getting into systemic steroids or systemic steroid-sparing agents and immunomodulatory agents are required for the minority. And all patients with lichen planus, regardless of the clinical subtype, regardless of if it's erosive or reticular, that's all completely out of date, regardless of whether it's painful or not painful, regardless of whether they need treatment or not. Everyone has an increased risk of malignancy with lichen planus. The data ranges from about 0 to 6%, but if you look at the systemic review, then you get about a 1% rate of malignant transformation. So everyone needs to be aware of that with lichen planus. They need to be clear on what they do if they get a lump, a hard area, or an ulcer that's not getting better, and how to follow up on that, and they should be screened. An example of that is here. Here's a gentleman who came in with what looked quite like a mixed type lichen planus with areas of erosion, areas of reticulation on the lateral tongue there at the bottom right, and erosion reticulation on the palate. And I would challenge anyone to find the cancer in that picture. but he does have a cancer. And the giveaway was that the top left picture, there's a little nodule there just to the lateral side of the posterior lower molar, which you might just be able to pick up. That was just slightly harder than the surrounding mucosa, and induration is a key feature of malignancy. So that was where I took a little biopsy, and it came back as this very, very small T1 tumor. So that was a chance finding, really. But it's very, very hard to see that. And it's worthwhile always remembering that these patients have this increased risk of malignancy. And that's the kind of tip there. There's your reference for a reasonably recent systemic review on that. Keeping on going then, to look at oral candidiasis, again, really, really common. Also probably the most misdiagnosed mucosal disease, especially by general medical practitioners. Often, normal tongues or coated tongues or normal oral coatings are misdiagnosed as pseudomembranous candidiasis. And that can cause a lot of anxiety for patients, especially when they don't have any mucosal disease. The key thing with Candida is there's usually an underlying cause. It's the disease of the diseased. So why is it there is always the question. And there's a list there of some of the things that can be underlying in oral candidiasis, and that always needs to be considered, and those things should be ruled out. And if you can figure out what the problem is, the treatment is really simple. There are a few subtypes you'll find again in the kind of classic classifications. Pseudomembranous is supposed to be the most common, although I have to say it's not the most common that I see. I see it very rarely. It may be that it's treated before people come to see me. Wipes off very easily. It's kind of this clotted cheese-like appearance. And underneath the whiteness, there is generally erythema. So it's an inflammatory reaction in the healthy patient. Acute atrophic is probably acute pseudomembranous, where the pseudomembrane has been partially removed, also called antibiotic sore mouth, but acute atrophic is the best way to describe that. Chronic hyperplastic, you usually see at the commissures, although it can be anywhere. It's a hyperplastic white plaque, also called Candida leukoplakia. Possible association with malignancy here as well, although they're much more common in smokers, so it's quite hard to see the wood for the trees there. And then chronic erythematous you can divide as median rhomboid glossitis, where you've got this rhomboid shape in the median surface of the tongue. There's often a kissing lesion on the palate where they touch, so you get a corresponding redness on the palate as well. And then denture stomatitis, which you'll all see all the time, particularly common in 24-hour denture wearers or people who aren't cleaning their dentures effectively. Angular cheilitis, then you'll see this redness at the corner of the mouth. Can be caused also by Staph aureus as well as Candida, but Candida would be more common. And then chronic mucocutaneous candidiasis would be by far the least common, and that's really a heterogeneous group. There's lots of things that can cause that, and it's really a kind of clinical term. Usually these things are present from childhood. They usually involve multiple mucosal surfaces, or the skin as well as the mucosa, or the nails as well as the mucosa. And they're usually, as I say, present from childhood. Only a few of the syndromes pop up in adulthood. Treatment for Candida, again, find the cause is the most important thing. Topical agents are probably as effective as systemic agents, although they can be a little bit longer in duration. And then for people who are getting recurrent Candida infections, just a daily chlorhexidine mouthwash can be quite an effective prophylactic treatment. Systemic agents, then you're into the azoles or things like amphotericin. A word of warning on the azoles, even when they're applied topically, is the big interaction with warfarin, where they function to hugely increase the INR. So even with topical azoles, there's a significant interaction there. The tip for Candida then is just, again, to bang home the point that why is it there? It's a disease of the diseased, so we need to think about what the underlying cause of this is, what's the deficiency, and how can we correct that? Okay, next topic up then is white patches, which will be kind of green or purple patches on that screen, but hopefully you'll be able to see something as well. This is really kind of a topic to think about, a differential. What causes white patches? And there's lots and lots and lots of things that can cause them. So you've got to spread your net wide to start with, try and think about everything, look at what's in front of you, listen to the history, and break down and rule out as many as you can, so you're left with a short list then of a differential to go forwards from. So if we take these subcategories in turn, well, traumatic would be the most common. Frictional keratosis, white patches on the cheeks, linea. linea alba, excuse me, we see these all the time in our daily practice. They're really of no consequences, no increased risk of malignancy. There's nothing much to say about that. Infection then would be the next one up. And viral, we're talking about human papillomavirus. We see these all the time as well. Little papillomas, they can have white stalks. They've got a verrucous kind of surface. And then Epstein-Barr virus causes oral hairy leukoplakia, these corrugated white patches on the lateral borders of the tongue, which are associated with immunodeficiency of any cause. Bacterial, we're really talking about syphilitic leukoplakia. Quite rare in my practice, quite rare in any of the oral medicine units that we see, but there is still a lot of syphilis out there in Dublin. The oral pathologists still see a lot coming in from lots of different referral sources, but it's not something that typically presents to the dentist. There's been one recent case of it with a colleague oral surgeon. Other than that, I haven't heard much of it in Dublin. Fungal infections, then, we've just gone through all of that, and it's acute pseudomembranous and chronic hyperplastic that cause white patches. Malignancy, the classic descriptors are homogeneous leukoplakia, speckled leukoplakia, and erythroplasia. I hate these terms because they give you absolutely no clue as to what's going on. All it says is you've got a white patch, but we're talking about the differential in a white patch, so it's really useless. There are also diagnoses of exclusion, which by definition then means you've got to take a biopsy, which means you actually know what's going on and you stop using those terms. So I really dislike those terms. They're only useful in the general sense that for the first time you see a patient, as you move down that list, you're more likely to have a chance of finding malignancy or high-grade dysplasia when you take biopsies. But really any white patch that has no cause is indicated to have a biopsy. And then we should really be moving on to these terms, which is hyperkeratosis with or without dysplasia. And you can grade that as mild, moderate or severe dysplasia. Then you get into carcinoma in situ, and then you're into squamous cell carcinoma. And those descriptors are much, much more clinically useful in terms of trying to predict the risk of malignant transformation and in terms of trying to decide how we're going to manage the patients. So really a white patch of no cause, which we may call a leukoplakia the first time we see it, needs a biopsy, and then we should stop using the word leukoplakia. It's not helpful. Lichenoid white patches we've talked about already, and I've given you the list there of the drug-induced lichenoid reactions. The big ones, antihypertensives, antihyperglycemics, and anti-inflammatory. So just think of those three antis for exam. You should be able to roll those off your tongue. The other ones are less common, although hydroxychloroquine is commonly used for the treatment of lupus, which is a reasonably common condition. And lupus can also look like lichen planus, so that can be a diagnostic challenge when someone is taking that for lupus. It's whether it's the chicken or the egg, or whether it's just lichen planus superimposed on top. Allopurinol is used commonly for gout, and the other three there in the list of others are much less common. The developmental causes, again, you'll be familiar with from your textbooks, from the very common at the beginning down to the much less common at the bottom. These things can all cause white patches. So in practice, what do you do when you see a white patch? Well, hopefully you can make the initial decision about whether it's normal or developmental or pathological. That's the first stage in your decision tree. If it's normal, you just continue to see them for whatever you're seeing them for, and you keep an eye on it. It shouldn't change, and that should be the end of it. If it's pathological, or if you're not sure, so if you don't know that it's normal, treat it as pathological. Then you start to think, well, is there an obvious cause for this? Is there a sharp tooth? Is there candida going on? Is there a drug that could be causing this? And you try to remove it if it's possible to remove it, or if it's beneficial to remove it. Review them a few weeks later, and then if it's still there, then you need to proceed to probably getting a biopsy, so then you've ruled out the cause. Sometimes there's an obvious cause, but it's not modifiable. So someone's taking a drug that would be responsible for this, but if they stop taking the drug, they're going to get sick. Well, we can't do much about that. You might go straight to a treatment at that stage, or you might consider a biopsy. And if there's no obvious cause, or the cause has been ruled out, white patch always needs to be biopsied because it carries a risk of dysplasia and malignancy. And from there you can go to specific treatment. So that's the final kind of tip in white patches. Any unusual pathology that's there for more than 2 weeks without an obvious cause needs urgent investigation. So a lump, a hard area, a white patch, a red patch, a brown patch. If it's not getting better after causes have been removed or there's no obvious cause, then that needs follow-up straight away. The final topic then is biopsies, and generally mucosal biopsies is what I'll talk about. The There's a few things to consider here, and again, it's an easy topic to come up in Vivas. It's an easy thing to talk about when you're prepared for it, and an easy thing to examine, which means an easy thing to ask. Well, why do we take biopsies? Well, a biopsy is when we take a small sample of something that we're not sure exactly what it is. Sometimes we use a biopsy to actually remove pathology. Other times we use it to actually get a diagnosis. And sometimes we use it to direct treatment. So we're choice between a few different treatments, and the biopsy can help us get more information about the condition so it can lead us down one or other path. There are a few different types that we can consider. From a kind of surgical perspective, we can use a punch biopsy or a blade biopsy. A punch is a circular scalpel. I don't have a picture of it here, but you'll get it easily online. And the shape is determined by the instrument, so you can choose your diameter. 2, 3, 4, 5, 6, 7, 8 millimeters in diameter, whatever you want. It's reasonably quick, reasonably simple, but the shape that you're leaving is not necessarily the ideal shape for the lesion. It's not necessarily the ideal shape for closure. A blade obviously is a different story, where you're using a scalpel and you can make it any shape you want. So you can customize it to the treatment. You can also plan for better closure, and it's much more adaptable. So if we consider the kind of green blobs there at the bottom to be the pathology or the area you want to biopsy, the colors there are showing you the kind of biopsies you can do. If we look at it the other way then and think of the other types of biopsy, forget about what surgical intervention you're going to do, you can call them incisional or excisional, perilesional or aspirational. And aspirational biopsy is not the one you want to do, it's where you stick a needle into it. So if we think about an incisional biopsy, if you were doing it with a blade, it would look something like that. Hopefully you can just make that out on the screen, where you're taking a small sample of the normal tissue and also a larger part of the lesion. With a punch biopsy, it'll look like that in red. Excisional, you're taking the entirety of the pathology, and you're usually taking a small margin. Depending on whether it's benign or malignant, the margin is going to be different. With a punch, you're going to have to be dictated by the size and, of the area, and the widest part is going to dictate the diameter of the punch biopsy. Perilesional biopsies are where we take not really the lesion in question, but the little bit beside it. So we usually take a tiny bit of the pathology in question and then what is clinically normal tissue beside it. And again, we can do that with a punch or with a blade, depending on the circumstance. And then an aspirate is where we put a syringe in and we actually try to suck out some of the contents of the pathology, and that gets sent off for cytology, usually with a fine needle. It can be ultrasound guided or it can be blind. So why do we do all of these? Well, the aspirate biopsy usually is when we've got no clear diagnosis or we're not sure of exactly what the diagnosis is. And it's generally for solid pathology, so a lump in the face or in a parotid or salivary gland, or where we've got cystic pathology and we want to kind of get a little bit more information about what's inside. Is it blood? Is it cystic fluid? Is it nothing? And it's generally done when we've got difficulty achieving direct access to the pathology. An incisional biopsy there, we've got direct access, we're not sure of the diagnosis, and malignancy may be suspected. So if malignancy is suspected, it's always going to be an incisional biopsy. And in this procedure, the pathology is not removed. So we're leaving behind the pathology, we're just taking a small sample of it to actually gain the diagnosis. An excisional biopsy should be considered if the diagnosis is clinically clear. You know what it is by looking at it, or you're 90% sure, or you can narrow it down to a small number of things, all of which need to be removed. And the actual treatment removes the pathology. And then perilesional is where we don't know what it is, but we suspect that it might be vesicular bullous. That's really the reason for doing perilesional tissue. And we usually take a sample that's perilesional and send that fresh tissue straight to the immunology department, where they'll do direct immunofluorescence and give us some information about what's going on. General risks: pain, bleeding, swelling. You get that every time you kind of lift a scalpel. We need to be aware of nerves in the area that can cause numbness. If we're doing gingival biopsies, we can get recession, and then the patient needs to be aware that you might have recurrence, or we might have the diagnosis wrong and need to do something else or not get the full picture from it. General surgical setup for a biopsy, you probably would be familiar with. You obviously need a scalpel, and there's your punch biopsy actually there, just third from the right, little white instrument. You'll need some instruments to remove the tissue, manage any bleeding, and suture. Quick run through a punch biopsy then. Here's a patient with generalized desquamative gingivitis. We're thinking about what might that be. So a little punch biopsy from an involved area. You can see the circular cut there. That little circle is then removed with a blade, and you're left with a raw surface. So there's the little sample being removed. That's a 5mm biopsy punch. You can see the sample there. In the gums, there's really no possibility for suturing, so you're healing by secondary intention. They tend to bleed quite a lot, especially when it's erythematous. This is a little bit of silver nitrate, which is very helpful for stopping that bleeding. If we look at a blade, kind of typical blade biopsy, that's a vascular type lesion. It blanches on pressure and refills. It was quite typically vascular looking at it, so I was happy with the diagnosis clinically. So we can remove that with a scalpel at right angles to the tissue, going around the lesion with a small margin, about a millimeter margin all the way around. Once you go all the way through the epithelium, the tissue can kind of lift up, which makes it much easier then to grasp it. And I'm grasping it here from the base, so I'm not damaging the surface or the actual body of the lesion. And then we can just cleanly remove it. You're left with an open wound. This is an elliptical kind of incision, so it makes it easy to close with a couple of sutures, and that's the end of the story. Very simple, and the procedure's done very quickly with minimal problems. Once you've got the biopsy taken, you then need to get that sample from your office or wherever you've taken the biopsy to the laboratory. It should go in formaldehyde and formalin, buffered formalin, with the exception of a direct immunofluorescence sample, which should just be moist in gauze and fresh tissue to go to the lab. It's very important to complete the paperwork properly. Check it, double check it, get someone else to double check it, because if there's any error on that, it just completely wastes everyone's time, and it can mean that you've got a tissue sample sent, a procedure done, which can't actually be analysed or reported. And always give as much information as possible. There's guidance on the appropriate transport there at the bottom. There's a link which you'll get on the slides, the handouts as well, and that gives the appropriate transport for this jurisdiction. Other jurisdictions may be different. So the final tip for this is, if you're taking biopsies and sending biopsies, give the pathologist as much information as you possibly can. The more information you can give them, the better a report you're going to get back, the more they'll be armed to actually help you. So always include the clinical details, the medical history, the medication, the social history. Always take a photo, especially if you're doing an excision. Have a photo of that pathology before you remove it. In the unlikely event that you get a diagnosis that's completely unexpected and is going to lead to further treatment, if you don't have a picture of what it looked like and you're referring to another clinician or getting third-party help, it's very difficult to actually know where you're going. And you should always have a differential diagnosis. If you can't get as far as a differential diagnosis, you probably shouldn't take the biopsy in the first place. But give as much information as you can to the pathologist, and that'll make their life easy and give you better results. Okay, we'll finish there. We've no time for questions, but I'll be around at the break if anyone has any specific questions. Thanks.
Thank you very much, Michael.
Thanks.
Thank you.
That's great. Thanks a million.